Thank you for joining us for the second half of the newly diagnosed session. If you didn't get a chance to attend the first half, be sure to check out the recording when it's available for replay today or tomorrow. In this second half of the session, Dr. Mary Schroth and Dr. Rob Graham will be sharing helpful information about treatments, trials, and care for symptomatic families and individuals. I would now like to introduce Dr. Mary Schroth, Chief Medical Officer at Care SMA. Mary?
Thank you, Sarah. Hello and welcome, everyone. I'm so pleased that you're able to join us today. I will spend the next few minutes discussing SMA and clinical care, but I want to share a little bit about myself before we get going. Before joining Cure SMA 3 years ago, I provided care to people with SMA as a pediatric pulmonologist in Wisconsin. In my role at Cure SMA, I can impact care on a larger scale, reaching not only patients, but also other healthcare providers as we continue to learn and share what we know about SMA. Next slide. As Kenneth mentioned earlier, support, research, and care drive the SMA community. This conference is an opportunity to bring the entire SMA community together. I will focus on SMA care and healthcare specifically. Thinking about your health or your child's health and making decisions that impact SMA healthcare occurs every day. Receiving a medication or medications that directly treat the genetic cause of SMA requires care to optimize the outcomes of these treatments. Next slide. You may know all of what I'm going to say in the next couple of slides, but I ask for your patience and to please allow me to review what we know about SMA. So we know that the underlying cause is due to a gene mutation, and this gene mutation results in much lower levels of survival motor neuron or SMN protein, essentially an SMN protein deficiency. And this deficiency results in disease of the motor neurons. This is a nerve disease. Motor neurons send messages from the spinal cord to the muscles, which then results in muscle weakness because the nerves are damaged. SMA is a degenerative disease. It results in not only muscle weakness, but also fatigue. And there are multiple parts of the body involved. We know about the muscles and nerves, primarily the nerves, resulting in function of the muscles, but also the muscles for breathing are impacted, muscles for swallowing, which impacts GI and nutrition, and also bone health. Next slide. SMA is an autosomal recessive disease, and what that means is that typically both parents carry one gene for SMA, and they have a normal gene. They do not have symptoms of SMA. However, when two people who are carriers for SMA have a child together, there's a 25% chance for each pregnancy that their child will have SMA. There's also a 25% chance that their child will not carry the genes and have normal genes. There's also a 50% chance that they will have a child who is a carrier for SMA. We know that the carrier rate is 1 in 50. We estimate that the incidence of SMA is 1 in 11,000 live births. Through newborn screening, we're learning what the current incidence of SMA is. And as we gather that information from all the state labs who are doing newborn screening, we'll be able to share that out. SMA is diagnosed by gene mutation testing in over 95% of individuals with SMA, and this is a blood test. The gene for SMA is on chromosome 5 in the location of Q of that chromosome 5. In an individual with SMA, again, both genes have a deletion on the SMN1 gene. The remaining 5% have a point mutation, and that's not picked up in the typical SMA gene testing analysis. What has to occur is gene sequencing in order to identify those point mutations. Historically, SMA is the most common lethal genetic disease of children under 2 years of age. However, with the treatments that are currently available, this is rapidly changing. Next slide. This is a graphic of the SMN1 gene and the SMN2 gene, or backup gene. SMN1 produces 100% functional protein. And if you have one gene that's working for with SMN1, you will not have symptoms of SMA. Next slide. For people who have SMA, their SMN1 gene is knocked out does not produce any SMN protein. And then the SMN2, which is a backup gene, kicks in. This gene is very inefficient in producing SMN protein. Approximately 10% of the SMN protein it produces is actually functional and helpful to the body and the nerves. 90% of that protein is non-functional. This explains why we are looking at SMN2 copy number in individuals, because SMN2 copy number in general predicts severity of disease. The more SMN2 copy numbers you have, the less severe SMA. But there are exceptions to this. Next slide. So to treat the genetic cause of SMA, which right now represents the treatments that are currently available, it was determined by the researchers who identified the gene, who identified the protein that gene produced, and that low levels of that protein resulted in the SMA disease. What they found is that enhancing that SMN production increased the SMN protein levels and also improved function and survival. So we have 3 currently FDA-approved treatments for SMA. And again, these are treatments. None of these medications is a cure. None of these completely take away having SMA. The first one that I want to talk about briefly is Zolgensma, which was approved in 2019. And this treatment replaces the function of the SMN1 gene. It's a small piece of DNA that lives in the nucleus of the cell and produces SMN protein. It does not become part of the DNA of the individual. An alternative pathway is focused on the SMN2 gene producing more functional protein. And there are 2 treatments available that alter splicing of the SMN2 gene. And these are Spinraza, which was approved in 2016. This is the first treatment that became available for SMA. And Evrysdi, which was approved in August of last year. And both of these 2 medications alter the splicing of the SMN2 gene so that there is more SMN protein available in the cell. Next slide. One comment I want to make about the treatments, again, is that they are not treatments, and we have a lot more work to do to identify additional treatments to help individuals with SMA improve survival and improve outcomes. So just know that as we think about treatments for SMA, we're not done. So now I want to transition into talking about SMA care. These treatments available for SMA have dramatically changed outcomes for SMA, both in surviving much longer than natural history or prior to having treatments available, and individuals are stronger than their genetics would predict without treatment. Because of the dramatic changes in SMA outcomes, care is more important than ever. We have several years' experience using these treatments. They have been closely studied in clinical trials. And just know that clinical trials, which Dr. Graham is going to talk about shortly, study ideal populations. So individuals with SMA that fit a particular age criteria or particular level of function and genetics. It doesn't represent necessarily everybody with SMA. And we need to learn more about how these treatments impact everybody with SMA. And with your partnership and as a community, we're continuing to learn about these outcomes and how to best use the treatments, especially in what we refer to as real-world evidence. So this is the information that we collect about these treatments after they've been FDA approved, and people with a variety of clinical situations are being treated. We recommend regular clinic follow-ups, again, to optimize treatments, optimize the treatment outcomes, and what is monitored at these clinic visits with your SMA care team are symptoms of SMA. Are they changing? Are there new symptoms? Are symptoms improving? And also side effects of treatments, in addition to optimizing the treatment outcomes. Next slide. This is a slide just demonstrating the multidisciplinary care that is required to care for individuals with SMA. It takes a village to care well for people with SMA. This list of specialists is not comprehensive. It does not include everyone. And depending on your needs, there are some specialists that you will see more often than others. But every care team for SMA should include multiple specialists. At the center of the care is the child or the individual with SMA, surrounded by family, and then by the clinic coordinator who helps with navigation through the health care system, and the many specialists as determined by the team. Next slide. So a standard of care is critically important to optimize function. Establishing a standard of care sets a baseline for what everyone who is delivering care to individuals with SMA should be doing. And I will share with you documents that were last published in the work that we're currently doing to update standard of care based on the information that we've gathered over the last few years. Areas of particular concern or interest and focus are physical and occupational therapy to optimize function and impact of new treatments, working with a physical therapist and or occupational therapist and swallow therapist as needed to assess where someone is at functionally and what things that they may need to improve their function. Nutrition is critically important. Growing and gaining weight is key to optimizing motor function and strength. If the body needs energy in order to continue to make gains. The swallow is also monitored. That is a critical piece of doing a nutrition assessment. If someone is not gaining weight well, part of the issue may be that their swallow is not optimal. And then there's breathing. Breathing requires close monitoring, especially after treatments, because there's not one way that individuals respond to the treatments regarding what they may need to support their breathing. So close monitoring, assessing what an individual needs, and then providing that support is critically important, and not waiting to see, will a treatment make a difference in a currently critical need. Providing coughing support and the ability to clear the secretions is so important. And then breathing support during sleep as needed. So the two areas of complications related to breathing are difficulty coughing and also just taking shallow breaths during sleep. And those are things that the pulmonologist will monitor and make recommendations. One of the things to know related to care is that viral illnesses make everybody weaker. There's a beautiful study done about 30 years ago that demonstrated that people without neuromuscular weakness or SMA have transient weakness in their respiratory muscle strength and other areas. So just know that a viral respiratory infection may change how someone is doing who has SMA. For a period of time, they may require more support. They may need support with breathing, with coughing. They may have some difficulty with swallowing. And these are all the result of a viral respiratory infection contributing to someone being weaker for a period of time. After they recover, typically that motor strength resumes back to baseline. Next slide. So this slide lists the most recent documents regarding SMA standard of care. These are available on our website. So the last version was in 2018. And as I showed you in the earlier slide, we've had 2 treatments approved since these guidelines were established. Care SMA currently is collaborating with healthcare providers throughout the country and also in Europe to evaluate current practices regarding SMA care. And we are focusing on 3 topic areas this year and planning to touch on other topics over the subsequent 2 years. This year we're focused on diagnostic considerations, so making diagnosis of SMA, what's new, what do healthcare providers around the country need to be thinking about. Treatment considerations, we are gathering information regarding how people are using treatments, what is resulting in best outcomes. These are questions that we all want answered as quickly as possible. And our third topic area is focused on SMA and emotional and mental health. This is an area that has not been attended to, but we all know that there are concerns there that need to be addressed. So our plan with updating the standard of care is to publish documents toward the end of this year, early next, and then distribute them widely so that anyone who is providing care to individuals with SMA has access to these documents and can provide the best care that we know of at the current time. Next slide. So Care SMA actively collects data regarding SMA in relation to treatments, care delivered, because we want to establish these evidence-based standards of care. It's not just putting people together and getting their opinions about what's best care. It's looking at what do they do, how are they delivering care, and what is the response to that care in our community. So one of the pathways is that Care SMA has partnered with 19 care centers across the country. And our goal is to achieve 50 centers in our care center network, and that will occur over several years. We currently have 19 centers. But these centers, as they see patients, they obtain consent so that information can be transmitted to Care SMA securely from the electronic medical record. And then that data is compiled and analyzed, looking at patterns of care that's being delivered, outcomes related to the treatments, and how the treatments are being used, and also survival. That information is provided back to the care center that provided it in a compiled way, and also provided back to the community. I encourage you to join us in our research and clinical care updates, and also other opportunities where we're sharing this data very actively with you. Next slide. So the last slide talked about clinician-entered data and collecting that clinician-entered data and details and moving that into our clinical data registry so that we can do analysis and ultimately create an evidence-based standard of care to guide clinicians all over the U.S. and all over the world regarding how you care for individuals with SMA. But another important component to understanding real-world evidence and what is happening in the community is to get your perspective. So we have multiple opportunities for you to share with us your experience having SMA, the treatments you've received, and functional levels. And the three areas are a newborn screening registry survey. So and this registry is specifically for those that were diagnosed through newborn screening or identified prenatally. So I encourage you, if your child is diagnosed through newborn screening, to please go to our website and answer approximately 20 to 25 questions. And we're tracking that over time, so you'll enter it initially, and then we'll come back to you every 6 to 12 months to ask you to update it. We also have a newly diagnosed survey. So for anyone who was not diagnosed through newborn screening, and if you have been diagnosed through newborn screening, we invite you to go in and answer a very brief survey about the newly diagnosed experience. And then every year we have a community survey, where we invite the entire community to provide us with feedback about their experiences having SMA, what treatments are they on, how are they doing, what are they able to do from a functional perspective. And that survey is currently open. If you go to our website at caresma.org, it will pop up and invite you to participate. And again, we encourage you to share your experiences regarding SMA back with us. And we use this to advocate for access to the treatments. We use this to educate healthcare providers. We use the information also to look for new treatments to help individuals with SMA. So again, and I thank you in advance for your participation in these surveys. And again, thank you for being here today. Next slide. Again, thank you. Feel free to email me if there's questions, mary@caresma.org. And it is my pleasure to introduce Dr. Robert Graham, who is Senior Associate in the Division of Critical Care Medicine, Department of Anesthesia, Critical Care and Pain Medicine at Boston Children's Hospital, and he's affiliated with Harvard University. Dr. Graham, take it away.
Well, thank you, Mary. And I offer really a heartfelt thanks to all the staff and volunteers at Cure SMA, as well as all of you who are in attendance today. You've taken a huge step as a newly diagnosed individual or family or friends of someone with SMA, just to be here, just to attend this session and to learn about SMA and the treatments, the trials, and the support that we have to offer. Next slide. As Mary said, I'm a pediatric intensivist, so I'm the ICU doc that you hopefully will never need to see and would prefer not to need to see. But I also run our home ventilator program at our institution and have been part of the SMA clinic since 2007, helping families and individuals navigate, their respiratory needs, their nutritional needs, the swallowing needs, and general care coordination. So my only true conflict of interest, as is on this slide, is really that my goal with you and your teams to make sure that we achieve your goals. I have been, as the disclosures say, been part of a number of research trials, both in SMA and other conditions, but don't have any commercial sponsorships. So next slide. So this is how I usually like to start this talk, and actually Kenneth has used this, as well as Tom Crawford, one of our senior neurology colleagues. And it's not that it has any numbers assigned to it, but rather it sort of reflects the history of the SMA community, and honestly the future and present of where we've been from a research and trials and treatment perspective. We've had ups and downs that sort of blue line the hype, the ups and downs with each historical research trial that wasn't successful. We get excited, the hope was always there, but the community, both researchers and families, actually all of us, the frustration was rising. And in fact, actually, I think the frustration we were seeing over the last 5-10 years was even increasing as we saw these the prospects coming forward. The hope has always been there, but I think we'd be remiss in not acknowledging that frustration still exists, and that varies for each family. And with you as a newly diagnosed family, you may have lots of fears, lots of frustrations, and yet persistent hope. Why did this affect me or my family? Why was there a delay in diagnosis? Why am I weaker or stronger than another child or young adult with the same SMN2 copy number? The questions and the frustrations, will I have as much of a response to a treatment as another individual with SMA? There's a lot to think about, and that's kind of what I want to do today. Next slide. My hope is to sort of, as we introduce this, think about ethical, emotional, and pragmatic issues related to medical research and actually treatments, to sort of give you a framework of how do I approach this? How do I even think about what the options are and anticipate the decisions that we might need to make? I want to review the different types and phases of research, and then really discuss sort of laying out goals and expectations of different stakeholders. You, the primary stakeholders, as the individual or family or friend of someone with SMA, but also recognize that there are other stakeholders. There's myself as a clinician or a researcher, or the pharmaceutical companies, lots of different considerations. And then, as you sort of reflect back on this session, and I encourage you to go back after you watch this or at some later point, and you can refer to my slides at any point, go to other virtual sessions throughout this conference. And honestly, we really hope to see you at future summits of strength locally. And, I cannot wait for 2022 when we can all be together again at our national conference. Next slide. So it really is a changing landscape. As Mary highlighted, it is amazing. We have, in less than the last 5 years, so December 2016, we have 5 approved treatments, not potential, but 5 approved treatments, with many more in the pipeline for SMA. You may have access to some of them, and this is one of the things that we're going to help you navigate. It is challenging, though. It is frustrating. It's like, why can't I get X when I can get Y? Is Y better than X? This is something we want to help you sort of work through. And the question is often, is a bird in the hand, better than the 2 in the bush? And the question is, this is what we want to help you determine. Next slide. I think as you're considering these things, it is helpful to be informed. You are in control of your medical care and your health. And if there's anyone here from Montana that's on this webinar, when I moved out to Boston 25 years ago, this was the speed limit as we drove through Montana, reasonable and prudent. Now, how you interpret that is up to the individual, and how you interpret that as a family or an individual with SMA, again, is up to you. But what I would encourage you to do, and what I want to run through today, is to be informed so that you know what are the risks and what are the benefits. Can I get there faster? What are the risks of getting there faster? And so reasonable and prudent, again, is up for interpretation. Next slide. Next slide. Yeah, thank you. So research. Traditionally, we think of research as a drug. It's a drug. This is what's going to happen, and we have to watch things happens, and that's how we got to the 3 approved drugs that we have now. We have nusinersen or Spinraza, we have Zolgensma, and we have Risdiplam or Everdis. These all went through clinical trials, and I'll talk about the different phases of that. And so yes, there are treatment trials, and there are treatment trials still going on, and that's helpful to remember. And you may be asked if you're interested in participating. But there are also other types of research which are essential, and Mary touched on a lot of those actually as we think about it. There's prevention and diagnostics. Like, how do we identify children earlier, or young adults earlier, or even adults who present with weakness for those with type 3 or type 4? We want to optimize the identification and prevention strategies and the care. There's screening, there's quality of life and supportive care. So for those of you who already have significant impact of SMA in terms of maybe your degree of weakness with your respiratory status, or maybe you have contractures or scoliosis, we still don't understand fully what's the best type of care. So there's research targeting that, or what's the best nutrition. There's genetic studies, and as I said, Mary alluded to the data registries and the surveys. Those are essential. Those are essential in helping us understand not necessarily what's the natural history, because we have continued to follow that, but what happens when in the context of treatment. How does that change it? And how does it change it for any individual? Because we know that SMA doesn't look like one thing, even if the genetics are the same. Next slide. So there are different care paradigms as we think about medical therapy and medical research. So medical therapy, if I go to the doctor, or any of you go to the doctor, and we say we have a cold, or they determine that we have high blood pressure, and anything that they prescribe, or a medication course or a therapy course, would be targeted at us. If you need to adjust your diabetic insulin, regimen, it's adjustable, it's targeted at you, and the intent is to improve your symptoms or improve your condition. That is tailored to you. That's the ideal. Medical research is different. You may receive it from the same provider, and like at our SMA clinic, we have both research trials, but we're also there as your research team. And again, that's one of the things that we have to help you navigate. We have to sort of remain objective in one side and then tailor it to you on the other side. But medical research, it's helpful for you to understand. It is not about you as the individual. It's about the study group. It's about the population. It's about taking everything that happens to you and pooling it with what happens to everybody else and saying this works, or it doesn't work, or it causes these problems. There's no ability to really sort of alter the dosing of that, or to change the protocol, the adherence to the protocol. Like, we have to adhere. Otherwise, the studies don't work and we won't move forward with the science. And so it's helpful for you to understand that as you enter a trial, there are going to be certain stipulations in terms of how long you have to be in and what you can and can't do with other treatments. And so it's helpful to understand that without adhering to that, we're not going to get to the numbers that let us move forward and determine, does that treatment work? We're interested in the global results, the statistical significance, and those statistics may not align with what you're experiencing, but it's helpful to differentiate that, and that may affect your choice to even enroll. Next slide. It's also helpful to remember, and this is a bit cynical, this quote, an investigational drug is a substance that, when given to a rat or a research subject, i.e. a person, produces a paper. And as I said, it's a bit cynical, but it does reflect that, yes, there are different stakeholders, and also the fact that if things don't work, sometimes they're not published. So we may not learn as much, and we are reliant on sort of that transparency and understanding that there's a lot more to learn as we move forward. And that's why even if you received a treatment, we would encourage you to stay engaged and think about, again, the data registries and the surveys and things like that, even if you're not interested in the clinical trials. Next slide. So research by the book. So the FDA does have a lot of rules, and you'll hear a lot about it. And we've certainly, in the context of COVID, heard a lot about FDA and approvals and otherwise. But these are the basic phases. And phase 1, 2, 3, 4 all happen after animal studies, the basic science, where they're doing in the lab, where they're in this, literally in the basic science, and then it moves to animals, and then ultimately it moves to people. And that's where we are with a lot of things at this point, that we've moved from basic science, and the 3 approved drugs have gone through all of these phases. You may be asked to participate in a phase. It's all about safety. This is really about, does the drug harm you, not does it help you? And so we've had historically, a lot of families that participated in phase 1 trials. When you think about how we got to Spinraza and how we got to Risdiplam and how we got to Zolgensma, there were families that had to make a choice to say, this has never been given in a person before, but I'm going to give it to my child, or I'm going to take it as an individual. And that was brave. And we'll talk about what their motivations may have been. Then there's efficacy, phase 2. Does the drug do something? Sometimes phase 1 and phase 2 are merged, or sometimes phase 2 and phase 3 are merged. But this is where we really sort of get into the, does it help? And this is where you might want to start asking questions. Is there a placebo group? So are there people who enroll in the study that get the drug versus those who don't? Or does everybody in the study get the drug? Do they get different doses? What happens if I wait until a little bit later? Do I get a higher dose or a lower dose? And so you ask those those questions, and just to be transparent, so you can again understand what are the potential risks and what are the potential benefits. Again, the families and individuals that within the SMA community that sort of helped us get to where we're at had to make some difficult decisions, and this is something you should talk to your providers about, and really understand the protocols. Phase 4, it is helpful. As we said, we have 3 approved drugs, or 3 approved treatments, but we are in phase 4 with these, and we continue to learn about these treatments even after they've been approved. And there are historically, in other conditions, drugs that have been used and have been taken off the market because after they've been dosed in hundreds of thousands or millions of people, we've learned that there are problems. Some may remember Vioxx. It was a pain medication sort of in the ibuprofen or Motrin family, but a powerful one that was on the market for quite some time. And then they found later on that it was correlated with strokes and bleeding. And so that was taken off the market. There was another drug, Felbutol or Felbamate, that was used for seizures, and that was found to have complications after hundreds of thousands of people have been treated with it. Now, this is something that we may not have the advantage of because there aren't hundreds of thousands of people that have been on the SMA drugs, but it's something to be aware of, and another reason to remain engaged, to tell people after you've gotten the treatment, are you having problems? Whether it's a year out or 5 years out, is it continuing to help you, or are there other issues? Next slide. This is the essential thing. First, do no harm. Started with Hippocrates, and I think this should be our primary driver. And again, this is both for you as the individual and family, but also for us as providers and researchers. And I think that's something we have to remember as we're embarking on all of these decisions. Next slide. So along with that is sort of the aligning the expectations and understanding. And I think these 3 basic concepts, the therapeutic misconception, the therapeutic misestimation, and the therapeutic optimism, all sort of, play into your decision-making to pursue a specific treatment or a research trial. And the question is, what does that treatment or what does that research hope to achieve? What's it targeting? Is it replacing the SMN1 gene? Is it targeting the SMN2 gene? Is it targeting a muscle? Is it actually, maybe it's just, it's a nutritional supplement. What is it that it's doing versus another prospective treatment or trial? The therapeutic misestimation. You may actually think that it's going to actually result in more of an effect than the researchers would anticipate. Or if it's a placebo control trial, we had families that would believe, yes, okay, for every 2 children that received a treatment, 1 child wouldn't, and we were comparing those groups. But there was always this sort of misestimation, or there's the potential for the misestimation. It's like, well, of course I'm going to get it. I'm not going to be in the control group. And so, you really need to sort of, again, calibrate your expectations. And then the therapeutic optimism is something that I think we all, would appreciate. We're all hopeful that it's going to work. And we should maintain that hope, but be realistic about it. Is that, the question is, and this is where some of the frustration that I spoke to early on comes. It's like, it's when your expectations and then the outcomes may not align that the frustration, it becomes even more amplified. Is that, it's hard to compare, one child who's got 2 copies of SMN2 to another individual child with SMN2. When we're looking at the research and the outcomes, when you're looking at your family, you're looking at you as the individual. Next slide. So you want to understand research, and this actually applies to treatments as well, but research specifically. So you want to understand the protocols, and understanding why some kids or young adults might be included. Is it age? Is it SMN2 copy number? Is it function? And so it's helpful to discuss this with your clinicians and your research team. You may want to learn about why is there washout. Understand, do I have to stop a treatment if I'm taking it daily, or if I'm getting injections every so often? Do I have to stop that? And if so, why? And what's the risk of me stopping it? Could I resume that treatment if something goes wrong in the trial or doesn't work? Confidentiality, this is something we struggle with as a community. We're a small group and we often know each other's business with social media and otherwise, but it's important to realize and protect yourself. These are decisions that you're making within your family. You may look to others to help, guide that, but this is a very personal decision. There are lots of other things to consider in terms of what are your commitments, are there incentives or disincentives to participating? You really need to understand what it is that this treatment is supposed to do. And as it relates to that, what are the risks? What are side effects? And if this is an industry-sponsored trial, they may have contingency and reparations if some things go wrong. Next slide. There are lots of other things to consider. Certainly, there are lots of benefits to being in a trial, no matter what it is. If it's a data registry, or if it's a drug trial, or if it's a physical therapy intervention, that you may have access to new treatments, whether they're a drug or just a supportive care measure that's not yet available to others. You'll get expert medical care or therapies during that trial because more people are paying attention to you. And there's the altruistic, recognition that you are helping others by contributing to research. But do think about the other risks. I mean, there may be side effects. The treatment itself may not work. And then there's other pragmatic things as you think about, there's stressors. If you have to come and go from clinic, is that clinic in your state? Is it out of state? Is it across the, is it an international study? There are potential trials elsewhere that you might consider. But this has impacts on you financially, on your family, on siblings, and it gets more and more complicated. And so it is worth having your home team help you determine what it is that works best for you and look at your goals. Next slide. And the fact is, it's not even that simple. There's lots of other things to think about, and it's only getting more complicated. As we're seeing blurring of the lines. We historically had SMA type 1, 2, and 3, and there were subtypes. And now in the context of treatments, that's moved. We're looking at SMA differently. And so it's hard to sort of judge who's eligible and who's not. And then really, as you're dealing with this as a family, it's like, do I want to pursue a new treatment? And as they say, is the enemy of good perfect? I mean, we don't have a cure, but we want to get things as close to that as possible and help you survive and be as well mentally and physically as possible. And so the question is, how do we titrate that and adjust that to your needs? Prenatal screening, essential. Talk to your families as affected individuals, have them consider prenatal screening if they're actually of childbearing age. And, as that pertains to newborn screening as well, advocate. If it's not available in your state, work with your SMA, try and get that on the newborn screen. And then look at things, can you, if you're in a trial, continue the therapy afterwards? What are we going to learn from the last trial? and recognize that there are trials still going on. Now, this is getting more and more complicated because, there are only so many people, thankfully, with SMA, but as a result, there are only so many people who can participate in trials. And as I said, research is about the statistics, it's about the numbers. And if there are less people in the trials, it's going to take us longer to learn and get new things approved. And lastly, as we think about treatments and trials, the clinical interventions and the support, which really dovetails with what Mary was talking about, the care centers and your care networks, this is what's essential. These have to happen in parallel. Spinraza, Everdis, Zolgensma are all phenomenal, but they need to be done in parallel with the clinical supports, because if we don't take care of you physically and mentally, you can't thrive and get the full advantage of these. So the physical therapy, the nutrition, the orthopedics, the respiratory, all of that, think about that and work with your teams around decision making. Next slide. So what are your options? As I said, we're a diverse group in terms of our, where we're coming from beliefs and values and our family structures. But the fact of the matter is you're all grappling with decisions in SMA, but they're very personal decisions. So you have to do what works best within your family. And if you're a two-parent family, you may or may not agree on certain things. And so that's something to work through, and that's understandable. And it gets more challenging as there are harder and harder decisions. But I think we also, as I said, there's hope in the prospect of new research and the drug therapies that exist, but couple those with your routine care and your management and work with your primary teams. Next slide. For those who remember Chutes and Ladders when it was, looked like this, and I'm dating myself, we're not at 100%. We're not at a cure. And so that's why we, encourage you to remain engaged with Cure SMA, remain engaged with research efforts, and learn a lot as you go along, because we've eliminated a lot of the chutes, and there have been some significant ladders that have moved us forward. But we've got a lot of work to do, and we want to help you navigate your individual paths. Next slide. So as I wrap up, I'm hoping it was able to give you a little bit of a review and a framework to sort of think about some of the things that affect, your decision making as you navigate the ethical, emotional, and pragmatic issues with research and treatments. Hopefully you have a little better understanding of the different phases and who's involved. And so I'd encourage you, again, refer back to this presentation, but look at the other virtual sessions throughout this conference. And, we can't wait to see you in person. Next slide. So thank you very much. And we look forward to seeing you in the future.
Thank you so much, Rob, and thank you, Mary, for sharing today and providing this valuable information on treatments, trials, and care. We appreciate everyone who's joined in today, and you will see a survey linked in the agenda page, and we would welcome any feedback that you have to share with us. And you'll also be receiving this survey link in an email as well. And once again, we're incredibly thankful for the support of our sponsors for making the 2021 Virtual SMA Conference possible. Don't forget to join us for tonight's Newly Diagnosed Mingle at 5 p.m. Central Time to connect and socialize with other recently diagnosed families as well. If there's anything that we can do for you, or if you have any other questions, please email us at familysupport@curesma.org. Have a great day, everyone, and thank you again for joining us for the 2021 Virtual SMA Conference.